Good morning. From that, you can hear that the recording has started. We are going to go ahead and start the Oregon Health Authority's Hospital Staffing Special Topics webinar. We have done two prior webinars that are available on our website, www.healthoregon.org/nurse staffing. And I am Anna Davis. I am the Hospital Staffing and Acute Care Regulation Manager, and with me is
Kimberly Volker. I am the Hospital Staffing Policy Analyst.
And we have a variety of topics to cover today, so we're going to jump right in. This first slide is actually just a screenshot of the dashboard that's on our website, and we update that every 2 weeks. We updated it just at the beginning of this week, and you can see that we have received over 2,200 complaints since September 1 of last year, including almost 2,000 of those just since June of this year. We currently have 472 complaints under investigation. We have completed the complaint investigation for 120 complaints, and in the investigations we've done, there have been 43 complaints in which one or more violations that was alleged in the complaint has been substantiated.
And I will say, just as a matter real quick of logistics before we get too much farther into this, we do in this webinar have a question and answer session at the end of this. You are able to send questions throughout, but if you are sending questions today, please send that to Tip. She has named herself to questions here. If you send it to either Anna or myself, since we are presenting, we may not see the questions, and Tip is here to help us sort through those questions, receive them, and answer them.
All right, so here's just the list of the topics we're going to cover today. We're going to talk about variances versus waivers, some CNA specific issues related to combined committees, complaints about staffing committees, staffing plan language, staffing plan approvals, staffing plans posted on the OHA website, what you can expect from those plans you see, permitted deviations versus safe harbor, because those are two separate provisions, and a little bit about safe table for hospital staffing concerns, and then we will have question and answer. So I'm going to launch right into variances versus waivers. Variances are the term we use for a variance described in ORS 441763 sub 6. This is for nurse staffing plans, and it's available for type A and type B hospitals. This permits a variance from the unit-based ratio requirements. These are the nurse ratio requirements in ORS 441765. Type A and type B hospitals are two kinds of rural hospital designations. So these are hospitals that are 50 beds or less, located in a rural area, and either 35 miles further, or at least 35 miles away from a larger hospital, or less than 35 miles away from a larger hospital. So if you're a hospital that has a federal critical access designation, you would fall within this category. There are other rural hospitals that are not critical access hospitals that still fall within this type A, type B designation. So those are the hospitals that can do that variance. And there's a process for it set out in the law where the hospital staffing committee approves the variance. They notify OHA, and by notifying OHA, that's when the variance kicks in. It's good for 2 years, and then the staffing committee must reapprove that variance. Waiver is actually something else. And I will note that the statute, both statutes use the term variance, but we use the term waiver for the thing that's described in ORS 441778, because we want to differentiate between variances and waivers. So the waiver is a variance from staffing plan requirements in ORS 441761 to 441795. It's available to any hospital if waiver is necessary to ensure the hospital is staffed to meet the healthcare needs of patients. The issue is it's a variance, or it's a waiver of staffing plan requirements. And the staffing plan requirements were in the prior law prior to 2023, and they were things like the staffing plan must set acuity. The staffing plan must list the total diagnoses for the unit. Those requirements are no longer part of the law. Those are things that a hospital can consider when setting a staffing plan, but they're not required to include that or even to consider that when setting the staffing plan. Because those requirements no longer exist in the law, there isn't really anything that we can grant a waiver for. So the staffing plan waivers, none of the old ones are enforced anymore, and we don't really expect to see any new ones because the requirements aren't there. If the requirements aren't there, then we can't waive a requirement.
And I will say to that, for any of those waivers that Anna is referencing from the nurse staffing requirements prior to 2023, all of those were related to that nurse staffing plan requirement about a minimum of one RN and one other nursing staff member on the unit. That's not something that exists that same way in statute anymore. And so that statute or rule that was getting waived, as Anna mentioned, is no longer exists, so that waiver is no longer applicable, just like Anna mentioned.
So I do want to clarify some things that can't be covered by a variance or a waiver. Neither one permits a hospital to avoid the requirement to have a staffing committee, the requirement to have a staffing plan, the requirement to release staffing committee members to attend staffing committee meetings. Neither waivers nor variances can permit hospitals to get around the mandatory overtime law, MOT, and there are no variances or waivers for BOLI's meal and break requirements. Again, BOLI enforces those meal and break requirements, but there is no waiver or variance. Now we're going to move on and talk about CNAs under the old law, under the new law, and areas that are still unresolved. So historically, CNAs were added to the Nurse Staffing Committee and Nurse Staffing Plans in 2005. That's 4 years after the original nurse staffing law. And they were included in that definition of nursing staff for mandatory overtime in 441-770. They're still listed in that statute. That's 441-770 is where it lives now. Previously, it had a different number, but the CNAs are still in there. And they are included in the Nurse Staffing Advisory Board, which is a statewide advisory board that was established by the 2015 changes to the law. And there is one member of that Nurse Staffing Advisory Board that can be filled by an RN, but is the statute specifies it can be filled by someone who is not an RN, and historically that has been a CNA. Under HB 2697, so the 2023 law, CNAs are still defined as direct care staff in the definition statute, which is ORS 441-760, and that's in sub 4. And they are still eligible for membership on the nurse staffing committee for the hospital. That's in ORS 441-762-1AB. And that is again, that nurse staffing committee reserves one spot for someone whose services are covered by a nurse staffing plan, a direct care staff member whose services are covered by a nurse staffing plan who is not an RN. So direct care staff, again, is defined as RN, LPN, CNA, so that position on the staffing committee in most hospitals is it's often a CNA. It could also be an LPN if there are LPNs at the hospital whose work is covered by the nurse staffing plan. The current law says a hospital may not assign a certified nursing assistant to more than 7 patients at a time during a day or evening shift or to more than 11 patients at a time during a night shift. That is ORS 441-768. That is the whole of the law. The term ratio does not appear in that text. Statute titles and the word ratio actually is in the title for that, but statute titles are added by legislative council after a bill passes, and they don't constitute any part of the law. So the title can't add to the meaning of the law, and it can't take away from the meaning of the law. The fact that they put ratio in the title for that statute doesn't mean that CNAs are a ratio per se. And ORS 441-792-2F, which is the violation law, refers to permitted deviations of the CNA 711 patient maximums as falling under the services staffing law. So says it refers to that services staffing law as where the permitted deviations are, which would mean that deviations of the CNA patient maximums would somehow be covered by the services staffing plan. So what HB 2697 did not address is whether CNAs should be included only in the nurse staffing plan, only in the services staffing plan, in both staffing plans, or in neither. And the law didn't address individual patients not receiving CNA care in units where CNAs are providing patient care. So there are certainly units in hospitals where there are no CNAs providing care. There are other units where there are CNAs providing patient care. The staffing law didn't say that the patients in those units all need to be receiving CNA care. It only said when CNAs are providing care, they can provide care to no more than 7 patients at a time during day shift or 11 patients at a time during evening shift, night shift.
And Anna, what I'll mention too is I imagine we might have a couple people in our audience who have had their hospital either have a complaint related to CNAs or submitted a CNA related complaint themselves and say, well, OHA's been doing investigations about CNAs. And what I want to address with that is OHA has done investigations related to CNA staffing levels as it relates to the CNA staffing levels in the nurse staffing plan. So those have not been a citation of that maximum number, that other provision that Anna is referencing. It's what we've seen thus far and what you can find on our website with the reports are investigations about CNA levels in the nurse staffing plan.
Where the nurse staffing plan provides either a minimum number of CNAs on shift or a maximum number of patients that a CNA can be providing care to, that's what we would investigate if we get a complaint about that, if it's in that nurse staffing plan.
Mm-hmm.
Okay, we're going to move and talk about combined committees under ORS 441-777. The nurse staffing, professional technical, and/or service staffing committees can be combined. Combined committee operations means joint meetings, separate co-chairs, separate voting. And the nurse staffing plans, professional technical staffing plans, and services staffing plans cannot be combined. Separate plans must still be adopted.
And so to really make that clear too, my understanding of this, Anna, is that those nurse staffing committee members, they're not voting on or passing the professional technical plan and vice versa.
Exactly. Although, because the statutes talk about how the plans have to take the other plans into consideration, the combined committee may be a good way to make sure you're all on the same page and reading each other's plans.
That you're not having conflicting information in them.
Yes. Okay, moving on, I want to talk a little bit about complaints about staffing committees. So staffing committee requirements are outlined for nurse staffing committees in ORS 441-762, for professional technical staffing committee in ORS 441-775, and for the service staffing committee in ORS 441-776. OHA can only investigate complaints listed in ORS 441792. And the committee-related complaints in that statute are failure to establish a professional, technical, or a service staffing committee, failure to create, adopt a staffing plan, failure to release staff to attend a staffing committee meeting. The statutes setting up the staffing committees have a variety of other requirements, things about charter and minutes and having the meeting open so that non-members can attend. Those are all requirements in the statute. OHA does not have the authority to enforce those requirements, so we can't investigate any allegations of non-compliance with those requirements. I want to talk a little bit about staffing plan language because I know there's often confusion. OHA can only enforce staffing, including ratios, that is written as required in the nurse staffing plan. So we can usually enforce staffing levels that are described as required, mandatory, maximum ratios, minimum numbers, staffing levels, must or shall. We may not be able to enforce staffing levels that are written as recommended staffing, ideal staffing, core staffing, allowed staffing, staffing levels may, staffing guideline, or other similar language where it's not phrased as a requirement. And I know we have also had questions about when we get a staffing plan that is phrased as recommended staffing or guideline, why can't we force a change? We don't have authority to change staffing plans. The authority to change a staffing plan lies with the staffing committee. It's the staffing committee that votes on that plan. So it's really up to the members of that committee voting to approve enforceable language, because then we can enforce that language. But we don't have the authority to change language that is not enforceable.
And our reports, the change that I really like about this new style that we've done is that it really explains if different language in there of, oh, we can't enforce this. It says this, so that's not enforceable. This part is enforceable. So those are very readily evident in the reports that end up getting posted on our website. And just something to remember is it didn't change from the old law. The direct care co-chair or nurse manager co-chair can call a meeting at any time to go over the nurse staffing plan. That's, I imagine, is true for service staffing and professional technical staffing as well, focusing on nurse staffing right now because that's what's in effect. That you can call that meeting at any time. You don't have to wait to update once a year.
And I will say, since you mentioned the online reports, that is a good place to see language that other hospitals have used and how that's been analyzed.
Mm-hmm.
Because you can see then whether we found that language to be enforceable or not. And we are, when we're doing that, we're getting guidance from the Department of Justice on the enforceability of that language.
And use that search function, use 2024, and you'll see all of the hospital staffing reports have been due in and completed in 2024.
And speaking of staffing plan approvals, for complaints that allege a violation on or after June 1 of this year, we look for staffing committee plan approval on or after September 1 of last year. Older approval dates reflect that the hospital does not have a plan that meets the new statutory requirements. So the plans that were approved before September 1 of 2023 can be reapproved after September 1 and still be in place. But if it was approved before September 1 of 2023, it is like, and not approved after that date, it does not meet the statutory requirements.
There needs to be some sort of documentation, like you're mentioning, that the staffing committee has looked at it, has made sure that they're looking at that staffing plan through that new lens of this new law. And like Anna had mentioned, that it is indeed compliant. So that's why that stamp needs to be after September 1.
And speaking of staffing plans, we post the staffing plans on our website. We are required to post the plans we receive. We do not have authority to review those plans for compliance prior to posting. And hospitals are responsible for submitting plans that are approved, current, complete, and compliant. OHA does not actually rely on these plans in our complaint investigations. Instead, during investigations, we request and receive from the hospital plans and information about plan adoption relevant to the complaints under investigation. So at the beginning of every complaint investigation, we're asking for that plan. It may be the same one posted on our website. It may not be. Hospitals are responsible for submitting updated plans, including updates made after an investigation. But we don't rely on that plan on our website to be the plan in the investigation. When we come out to do, or when we remotely come out to do an investigation, we are asking for that plan every time. And the plan you give us in the investigation is the one we will rely on and use in that investigation.
And the complainant has 60 days to submit their complaint. And then we have, after determining that this is a valid complaint, we have 30 days to start that investigation. So it may very well be that the nurse staffing committee has adopted a new plan. It's now on the website, but we are measuring against when we do an investigation, we're looking and comparing to the plan that was in effect at that time of the complaint. So that's part of the reason too why, it may be that the website has the more updated plan, but that wasn't the plan that was in effect at the time of the complaint.
For example, if you file a complaint about June 2nd, it's now too late to do that because it's been more than 60 days, but if you filed a complaint about June 2nd and they adopted a new plan on July 1st, we'd be looking at that June 2nd plan, not the July 1st plan. Okay, now we're going to talk about permitted deviations versus safe harbor. Permitted deviations are within that staffing plan law, and they are a deviation from the required staffing in the approved staffing plan. A hospital is allowed to have up to 6 permitted deviations per unit in a rolling 30-day period. The permitted deviations must be reported by the unit manager to the appropriate staffing committee within 10 days of the deviation. And that permitted deviation can be, we were off ratio for this period of time, or we did not have, if the plan instead of a ratio sets a minimum number of nursing staff members on the unit, it could be we didn't have our minimum numbers for a specific period of time. That period of time cannot be longer than 12 hours. If it's longer than 12 hours, that would need to be more than 1 permitted deviation. I want to contrast this with the safe harbor provisions, because safe harbor is described in what was HB 2697, section 19.4. It's now in ORS 4417934, and that is, if a hospital takes the actions described, OHA may not impose a civil penalty. So the actions the hospital has to take to avoid civil penalties are schedule staff in accordance with the staffing plan, sought volunteers from available qualified employees to work extra time, contacted qualified employees who made themselves available to work extra time, solicited per diem staff to work, and contracted temp agencies that the hospital regularly uses if temp staff are permitted to work in the hospital by law or any collective bargaining agreement. So a hospital would need to do all of those things, and then there would be no civil penalty for the violation. The violation occurred, but there is no civil penalty. Whereas in a permitted deviation, it's not even whether or not there's a civil penalty. that was not a violation because you used your civil penalty, or you used your permitted deviation, sorry. Safe harbor efforts are voluntary. A hospital does not have to do all of these things. It is a choice by the hospital administration. And I just want to quickly say, historically, we had a safe table for hospital staffing. It was the Nurse Staffing Collaborative that was run by the Oregon Nurses Association and the what was then the Oregon Association of Hospitals and Health Systems. They have since changed their name to the Hospital Association of Oregon. But they ran a safe table to facilitate a confidential forum in which hospitals and direct care staff exchanged ideas about challenges and best practices to improve hospital staffing, specifically it was nurse staffing, and to comply with the law. There is currently no active safe table for hospital staffing. OHA is the regulatory agency, so we're not a safe table. We are always happy to work with any organization that sets up a safe table, and we can come and provide information, and then we leave so that the group can talk together and come up with solutions and disclose things that might otherwise be non-compliant without us present. So at this point, we are going to move into answering some of the questions we've received in advance of this meeting, as well as questions you are sending in right now. And again, I would ask that you send those questions to the mailbox or the participant named questions here.
Yes, we will not necessarily be able to see otherwise the chat that's coming in. Anna and I will be focusing on answering those questions. So indeed, please send them to tip at questions here. It's all caps to help make it easy to see.
And I will kick off with a question about CNAs. What is the recourse for CNAs who are being made to care for patients without being assigned to avoid violating a ratio? So in any investigation, we look for the documentation of who is assigned to provide care to whom. And we would look for documentation of what care that CNA was providing during that shift.
And I know that we've done investigations, as I mentioned earlier, related to CNAs. And so when we're seeing a maximum number of patients that a CNA can perform tasks for, or if it's called a ratio, we're looking to see ultimately what is the CNA doing and how many patients are they providing care for, because that ultimately, regardless of the specific word in use, we are still going to be looking to see what they're doing.
We also have a question about if CNAs are assigned tasks instead of assigned to patient teams, would that limit the number of patients a CNA could do tasks for?
So again, if we see 1 to 7 or 1 to 11, depending on the shift, we're going to see, okay, how many patients is the CNA providing care for? So providing tasks. And is that more than 7? Is that more than 11? Ultimately, as well, that's all with the assumption that that is also at this point in the nurse staffing plan, because at this point we're doing investigations for CNAs related to the nurse staffing plan.
We have a question on what type of documentation will you be looking for regarding I think this means to be deviations to the staffing plans and notification to the staffing committee.
So far with investigations, it's mostly people are saving emails, and that works just fine. They'll save the email that the unit manager sent to the nurse staffing committee, and they'll provide us with a big bundle of emails during the investigation, and we'll see, okay, this email happened, that email happened. that's been working pretty well. I would just say make sure or pay attention to email retention schedules that your institution has, and perhaps consider saving those as PDFs.
And I would also note a hospital could develop a form.
Mhm.
That would be fine. You know, we're looking for written documentation. We have a question: if a staffing plan is violated, but the hospital followed all steps to fill the hole, so that's a safe harbor. The hospital did all the safe harbor requirements. Will the hospital be found in deviation and not fined, or will the deviation be left aside? So a hospital would get a written warning in that circumstance.
Only if there's a violation, though, because
Yes,
they mentioned deviation in this question, but it is important
true.
To recognize the deviation versus violation. So the deviation, as we're mentioning,
A permitted deviation, there would be no sanction, but when it says all the steps to fill, I read that as the safe harbor steps.
with the violation.
And so that is a violation, but it results in a warning and not a civil monetary penalty. Again, civil monetary penalties don't start until June of 2025. But even then, if the hospital did all the safe harbor things, then there would be no civil penalty for that.
So as an example to illustrate some of these, if you have deviations from a staffing plan and we do an investigation, see that there have been 5 permitted deviations, that is no violation, like Anna said. Now, if we go in and we see that this is number 8 in a 30-day rolling period, we now have a violation, and we're going to check, did they do the safe harbor provisions like Anna mentioned? Now, if they did all of the 5 safe harbor requirements to gain safe harbor, and like Anna mentioned, it's still a violation at that point, but no civil penalty.
We have a question: what are timelines for critical access hospitals, including service staffing committees? Those timelines are the same for all hospitals. Hospitals are required to have their service staffing committee and their professional technical staffing committee, and the staffing plans from those 2 committees as of December 31, 2024. So all hospitals across the state need to have that by December 31, 2024.
I see a few questions related to what types of areas require staffing plans. Some of these are asking about nurse staffing plans, about hospital staffing plans. The overall theme that I would mention is it's not about inpatient versus outpatient. It's not about whether staff are being scheduled, or whether patients have a schedule like with an ambulatory clinic, or it's all about, are the staff in that unit providing the type of service? So for nurse staffing plan, are there nursing staff members providing nursing services to patients
regularly in that unit? The definition of what is professional technical or what is services may vary from hospital to hospital because of the way that's defined in statute. So an RN is an RN is an RN. And that means that an RN in a med surge providing nursing care services is, it would, I can't think of an example of when an RN who provides nursing care services in a med surge unit would not be covered. But at one hospital, respiratory therapists may be professional technical staff, and at another hospital, they may not. And that's really going to be a hospital by hospital determination. So for professional technical staff, it may not be what unit you work in. If you are covered by a plan, you clearly work in a unit, however that is defined. But it may not be that the unit is what determines whether you are covered. It's whether you are the kind of staff covered at this hospital. We also had a question about special inpatient care facilities. There are just 3 of those in Oregon. And the question was, because they're not listed in the rules, do they just follow their approved nurse staffing plan? Special inpatient care facilities are a very small hospital under the law. And so they are covered by the same requirements. They have to have a new plan that was approved after September 1 of 2023. They have to follow all of the requirements of the nurse staffing law. They aren't named in the law because because in the law they exist as hospitals. So that's why they aren't called out as special inpatient care facilities within the nurse staffing law. We have a question about whether staffing plans expire.
That is a good question. So, as Anna mentioned during the presentation, those staffing plans from prior to 2023 need to have been adopted sometime between September 1, 2023 and June 1st, 2024 to be in compliance with these new requirements. After that, the statute has requirements about when the nurse staffing committee reviews the plan, that the staffing plan itself, my understanding is those don't expire as long as they've been updated by June 1, 2024.
Yes, so it could be reviewed. Let's imagine 2026 for a minute. It could be reviewed in 2026 and no changes made. As long as it's been reviewed, then that staffing plan would still be a valid plan. And I would also note the review requirement is one of those things that's in the statute as a requirement that we don't have enforcement authority over. So if there's a complaint that the plan has not been reviewed since 2024, we wouldn't have any authority to investigate that. We have a question about, is the staffing plan required for non-24 hour staffed areas? And again, as Kimberly was saying, it's not how often the unit is operating, it's how the unit operates when it operates. So an operating room, for example, may not be running 24/7, would still have a nurse staffing plan because nursing care is provided there on a regular basis. Now, there may be, I often use the example of an imaging department because there are some hospitals that have an imaging department that is big and running 24/7 and has nurses who are stationed in that unit and providing care in that unit whenever it's open. And then there are other smaller imaging departments where if you need nursing care, you bring your own nurse from whatever unit you were on before. So the one that has nurses in it and is always running with nurses providing that patient care, that one would have a nurse staffing plan. The one that you bring your own nurse wouldn't really need a nurse staffing plan because there aren't nurses who are assigned to that unit.
I see a question as well about the current number of complaints, which we do, as Anna mentioned, we have that on our dashboard and broken out by the type of the status of who's submitting these. So is it staff, is it family, is it patient? So I will say an interesting thing about the hospital staffing law is that the statute itself limits that complaints be submitted by a hospital staff person or their exclusive representative, so the union who represents them. We do have other routes for family and patients to submit care, and those are related to an individual receiving care at a hospital. That tends to go through our federal review. The hospital staffing is really submitted by staff people or their unions.
Yep. So of the over 2,000 complaints we have, they are all from hospital staff or exclusive representatives from the unions. And again, that dashboard is right up top on our website, so you can always see how many complaints we have.
I see a question about the combined committees. It says there was a slide about combined committees that said the meetings are joint, but there still has to be separate co-chairs and separate voting. Does that mean the larger group does not vote on everything? And so for the staffing, as it relates to the staffing plans, it can only be professional technical, voting on the professional technical, nursing on nursing, service staffing or service staff members for the service staffing plan. If there is a way that the committees want to operate together and there's policies or whatnot, that's not considered in the law. It's not addressed in the law. It's really the law itself is talking about how those staffing plans are getting passed. And so you won't have the large group that's fully combined voting on plans together. You're going to have those separate groups.
You may have, they may all be
Mhm.
together when the voting occurs,
Mhm.
but the votes for that specific plan have to be from the service type that is with that plan. So the nurse staffing committee, the service staffing committee, the professional technical committee may be all meeting in that room, but if it's a nurse staffing plan, only the nurse staffing committee members vote.
There's a question here as a clarification question. If an RN works anywhere under hospital license, then does that work need a nurse staffing plan? That again requires consideration of, are they providing direct nursing services? Because RNs have a variety of roles in a hospital. And I think an example that we often use is
Discharge planning?
discharge planning is one. I was thinking of the PICC line example, where there might be a team that comes to place a PICC line on a patient in a unit, and that nurse who is normally assigned to the unit is still assigned that patient. They're the ones still providing the direct services, whereas the PICC team is coming, they're placing the PICC line, and then that's not considered not as often considered a unit that would need its own plan.
It can be, though. It can be a unit with its own plan. It can also be covered instead by the plan of the unit on which they're working. It would really depend on what's in the plan.
Exactly.
We have a question about how is enforcement different for a service staffing committee? Enforcement is the same for all committee types and for all of the listed violations in ORS 441772. The only difference is that service staffing committees, that requirement to have one and the requirement to have a plan isn't until December 31 of this year. And that is also true of the professional technical staffing committee and plan.
And so I see a question here. We talked a little bit about this earlier, about how the process for amending a hospital staffing plan. This specific question used or asked about asking labor to require the employer to renegotiate. I do want to make it very clear that this is separate from a bargaining process. So whatever staffing committees you have, that's going to go through the staffing process. And either co-chair of the staffing committee can call a meeting to amend a staffing plan at any time. So this isn't your union contract. It's not the same as bargaining. These are separate things.
We do have a question about overtime for RNs that stay on site for meals or breaks. That would be a question for BOLI. The Bureau of Labor and Industries is the agency tasked with enforcing the meal and break provisions. So I would always refer people to BOLI.
We have a question here about there being two different hospitals in the same health system and service department managers addressing both hospitals and wanting to know if they can have a combined staffing committee between two hospitals. So Hospital A and Hospital B with one service staffing committee.
No, they cannot. The hospital
Mhm.
staffing committees are by licensed hospital.
Mhm.
So they may well choose to have a joint retreat, but they need to have separate committees.
Think of it similar to nurse staffing, where each hospital needs to have its own nurse staffing committee. That's true for professional technical staffing committee and service staffing committee as well. So I do see a question here about, is there a centralized public database of hospital staffing plans?
And there absolutely is on healthoregon.org/nurse staffing. You can see all of the plans that we have received. As we receive them, we post them.
I see a question, is it okay to combine meetings for service and professional technical staffing committees? You absolutely can combine the meeting, but those different groups would need to vote each on their respective plan. So only the service staffing committee voting on service staffing plans, only the professional technical committee voting on professional technical staffing plans.
I saw a follow-up question on the PIC line and whether they are not considered direct nursing care. They're absolutely direct nursing care. The question is that team by itself a unit, or are they part of another unit? We also have a question of, are non-patient care areas like engineering, supply chain, medical records required to have a staffing plan? That's going to be a hospital by hospital determination, because it's going to depend on whether the folks working in those areas are considered at that hospital to be part of professional, technical, or services staffing groups.
I see a similar question related to that about the pharmacy in the hospital staffing wide plan, and that's going to be like Anna mentioned, another one of those considerations where it may vary from hospital to hospital.
Similarly, we have a question about revenue cycle or health information. And again, what I would say is that that again is going to be, are they professional technical staff at that hospital, or are they service staff at that hospital? And if they're not, then if they're neither of those, then they wouldn't have a staffing plan.
So I see a question related to how the deviations per unit count. So it's each deviation as it relates to that unit plan. So you've got your unit nurse staffing plan, you have your professional technical unit staffing plan, you've got your service unit staffing plan. An important thing to realize, because the professional technical and service staffing are working, they have different scopes, they're working differently. There may be different units, it may be defined differently, but it's the way that those permitted deviations is from each of those staffing plans.
We have a question about the multidisciplinary committees that set the psychiatric unit staffing plans. And the question is whether there's policy language indicating which specific types of disciplines have to be included in that committee. I will note that there isn't a definition within the law of the multidisciplinary committee of what that has to include. And OHA also does not have rulemaking authority to define that. OHA's rulemaking authority in this law was very limited. And so we don't have the authority to determine what multidisciplinary committee requires. So that may actually differ from hospital to hospital. We have a question about should a CNO be voting in the nurse staffing committee? And that will really depend on whether the CNO is a member of the committee or not. In some hospitals, the CNO is a member of the committee. In other hospitals, there are sufficient nurse managers and the CNO is not a member of the committee. So it's really, that's up to that nurse staffing committee. The CNO can only vote in the committee if the CNO is a member of the committee and therefore sits in one of those nurse manager seats on the committee.
I do see a few questions asking about timelines for investigations. So the statute directs OHA to complete those investigations within 80 days. As we mentioned at the beginning of this, we have received just under 2,000 complaints since June 1. So that is far more complaints than we have ever received before. And we went from about an average of 30 per month to more than 30 per day. So we are working as quickly as we can to get you your reports in a timely manner. We know that some of them are overdue, but please know that we are committed to getting those done, to getting those posted so that you can have feedback on that.
We also have a question asking for guidance on when type A and B hospitals request a variance. That is correct. Only type A and B hospitals can request a variance. And that is an official request from the staffing committee that has approved that variance, as opposed to a waiver. Under the law, a waiver was requested by the CNO after the staffing, under the old law, the staffing committee reviewed that, but they didn't have to approve it or disapprove it. They had to just be informed of it. But because those requirements that were waivable no longer exist, there just aren't any waivers at this point.
I do see a question about how combined meetings work with the voting. What I do want to, as well as and quorum, I do want to talk a little bit about the equal voting and quorum because that was something from the nurse staffing requirements that continues into professional technical staffing and service staffing. A quorum happens when you have 50% of the committee plus one. So it can be any combination of staff members and manager members. You just need the 50% plus one. When it comes to voting, that's when the equal numbers comes into play, and you need an equal number of the staff member and the manager members voting. But you do not need an equal number of staff and manager members to have the committee meeting.
I will note we are coming up on 11 a.m. That is our set end time. We can go a little bit longer, but we do understand and respect your time. So we know that some people may need to leave. There will be the recording of this webinar will be posted online on helporegon.org/nurse staffing. And the webinars are right close to the top. We are working on a rebuild of that page that will make it into smaller, more manageable chunks. But for the moment, it is still one big page, but the staffing, hospital staffing webinars are right there on top.
I see a question of, for a combined committee meeting, do you also have to have a co-chair for each group? And yes, so the service staffing committee needs to have service staffing co-chairs, you need your professional technical co-chairs, and you need your nurse staffing committee co-chairs. So that is a requirement, even if you are combining those committees, you still need a co-chair for each of those groups.
We have a question about hospital sites that have outpatient services located on the hospital grounds, like phlebotomy. Should those staff be included in the hospital staffing plan? the hospital staffing, the nurse staffing, services staffing, professional, technical, those apply in any of the hospital licensed spaces. So if that staff is covered, they're covered regardless of whether it's a hospital satellite or an on-campus outpatient or an on-campus inpatient space.
We have a question that popped up during nurse staffing as well. And I imagine it's popping up now more because of professional, technical, and service staffing. It's, are exclusive representatives able to be members of the committee? And that's going to depend on the specific role of that individual at that hospital.
Right. The question isn't whether they are active in the union. The question is whether they're employed at that hospital. They need to be employed at that hospital, providing services at that hospital in order to be a member of that staffing committee. Someone who is employed full-time by the union, works in a union office somewhere and does not work at the hospital is not actually qualified to be a member of that staffing committee.
We do have a question about, for those smaller hospitals, is there a minimum number of required members? And so the statute directs that each unit needs to have a representative and a direct care representative or a staff member representative. And there needs to be an equal number of staff members and manager members on that committee. So I've seen it was one of the special inpatient care facilities, which are our hospitals. That one was very, very small and had 2 co-chairs and 2 non-co-chair members to equal up to 2 direct care and 2 manager members. And they were, they're very, very small, and that worked. For other ones, if you have more units than that, though, probably won't start needing larger committees.
The reason it's 2 and 2 for a 1-unit facility is because that nurse staffing committee has to have 1 direct care RN plus 1 other direct care individual who is either an RN or who is an LPN or a CNA who works in a unit covered by the nurse staffing plan. So the fact that that special inpatient care facility had CNAs working at it meant you would have 1 RN, 1 CNA. They're both from the same unit because there's only 1 unit, and they make up the direct care side of that staffing committee.
And I think in this one, it was actually an LPN, which those are, it's fun and rare to see an LPN sometimes. But LPNs can sit on that spot that we most often see CNAs because it's more common to see CNAs at hospitals. There's not as many LPNs, but if you have an LPN there, an LPN can sit on in that spot too.
As long as they are providing care in a unit that is covered by that staffing plan.
Yes, so LPNs would be in that nurse staffing plan.
Mm-hmm. And while we're on that subject of LPNs, if your nurse staffing, if your unit, if your hospital has LPNs working in a specific unit, then that staffing plan to have enforceable LPN numbers would need to specify the LPN numbers for each shift.
Exactly. And with that language that Anna mentioned earlier, with the required, the mandatory, the minimum, that language for the enforceable aspects of it. If we see guidelines, that's less likely to be enforceable.
Or if we see
core?
Well, core, I was thinking number of direct care staff specified in the plan without breaking it down as to whether we're talking about RNs, LPNs, CNAs. If the plan itself doesn't break down and say this many RNs, this many LPNs, it just says total number direct care staff, then we have difficulty and we may not be able to enforce any specific kind as long as there was an aggregate total that matched the aggregate total required by the plan.
the best thing to do when developing any of these staffing plans, be they nurse staffing, professional technical, or service staffing, is to imagine, okay, what if what if this entire unit won the lottery tomorrow and someone else had to come in here and pick this up? I know it's far-fetched because you're all hospital staff people, so you're probably showing up anyway. You're caring about the patients. I know this, but we're all gonna pretend here. And someone needs to pick up that plan and needs to know how this unit is going to run. That plan should be clear enough that anyone can walk in, someone who hasn't been on this unit before, pick up this plan and say, I know what staff are covered underneath this, and I know what we require at any moment. And I'm ready to run this. And I know we're coming up on 11:05.
I think we can do just a couple more questions. We have a question of what if a manager oversees several units? And that does happen. We are well aware of that. But the designation of managers on the staffing committee is not unit based. So you may have 3 managers from the ED and none from the OR, and that's okay because it's the hospital administration who decides which managers serve on the staffing committee. In contrast, the direct care nursing staff, you have to have one from each unit. So that's always been an area where the hospital administration, when they have that combined management for several units, they can get managers from somewhere else to be on that staffing committee. They don't need to have just the one-to-one from each unit. Okay, we'll do one more question.
And it looks like we gone through a lot of these. What I will say, I've seen just general questions about where to find things and how to get information on new updates. We do have a listserv that you can sign up for that via our website. And I will say too that our hospital staffing website, I'm used to calling it the nurse staffing website, that our hospital staffing website has several resources. It's got our reports, so those are all public, and they are posted on the website. You also will see our staffing plans are on there. We have these webinars will be posted on the website. It's the turnaround has been faster. It's usually
About a week.
Usually about a week. It's been a little faster than that, but recently, but a week is probably a good estimate. We also have
an FAQ which we updated in September. That's right there on the website. And that has a lot of useful information. And we also always have information about our nurse staffing advisory board that's specific to nurse staffing. And we do have a board meeting coming up at the end of this month. And so the board materials will get posted there.
And I just put that website link in the chat for you. That's
it's also showing.
It's also on it's showing right there. It's the www.healthoregon.org/nurse staffing. It is indeed that one that says nurse staffing. Anna mentioned there may be some shifts happening on that website soon, but for now, nurse staffing is right there. And it covers all hospital staffing.
We did ask for that for that short URL to get changed, and so far our IS team is telling us no, but we'll keep pushing on that. We also included on this slide the information for BOLI. Again, they're a separate agency. They have their own processes, but we provided the link for their website, their email, and the place where you can actually go directly and file a meal and rest break complaint with BOLI directly, because again, they're the ones who enforce that law.
And I will say, we do have on that complaint form an area for you to say, I want OHA to refer it on my behalf. My understanding is we do end up referring those, but my understanding is that Bully will typically request that complainants fill out their form. So it may just be easier to go through that Bully website. We have links to it in several places, but I do just want to put that as a warning. If you do use the OHA form, it will get to Bully. You might have to fill out another form.
And I also want to note, we are planning another webinar, likely end of November, beginning of December, about professional, technical, and service staffing, committee requirements, plans, and answering questions for that specific audience. So we will put that out on our listserv. We'll announce that. We'll also announce it on our website. And with that, we want to thank you for joining us this morning, and thank you for your time. And again, thank you for your commitment to safe staffing in Oregon.
Thank you, everyone. Have a wonderful rest of your day.